Good day, dear students. My name is Raspayeva Janalsina Muratovna. I am a head teacher of Obstetric and Gynecology Department, named after Alash Akhmetchanovich Kozbagarova. I want to present for your attention today's lecture, Arterial Hypertension in the Pregnant Women. Lecture outline. Introduction: the concept of arterial hypertension in pregnant women, clinical picture and diagnostics. The concept of arterial hypertension, in general arterial hypertension, is a persistent increase in blood pressure, systolic 120 and diastolic 80. There are two main categories of hypertension: primary and secondary. Hypertension during pregnancy can be classified as one of the following: chronic hypertension and gestational hypertension. Chronic hypertension, high blood pressure before pregnancy or before 20 weeks of the pregnancy. Chronic hypertension complicates the course of 1 to 5% of all pregnancies. Gestational hypertension develops after 20 weeks of pregnancy and resolves by 6 weeks postpartum period. It occurs in 5 to 10% of pregnancies, most often the multiple pregnancies. Both types of hypertension increase the risk of preeclampsia and eclampsia, as well as other causes of maternal morbidity and mortality, including hypertensive encephalopathy, stroke, kidney failure, left ventricle failure, HELLP syndrome. The risk of fetal mortality or morbidity is increased by decreased uteroplacental blood flow, which can cause vasospasm, growth restriction, hypoxia, and premature placental abruption. Preeclampsia is a multi-system pathological condition that occurs in the second half of pregnancy, characterized by hypertension in combination with proteinuria, often edema, and manifestations of multiple organ failure. What are the risk factors? Preeclampsia may be eclampsia or previous pregnancy. Family history of preeclampsia, multiple pregnancy, chronic stomach disease, young pre-gravidas and over 14 years of age, antiphospholipid syndrome, and birth interval more than 10 years. Clinical manifestations of preeclampsia: from the central nervous system, headache, photopsia, paresthesia, fibrillation, convulsions. From the cardiovascular system, arterial hypertension, heart failure, and hypovolemia. From the urinary system, oliguria, anuria, and proteinuria. From the gastrointestinal tract, pain in the epigastric region, heartburn, nausea, vomiting. From the blood system, thrombocytopenia, hemostasis disorders, hemolytic anemia. From the fetus, intrauterine growth retardation, intrauterine hypoxia, and antenatal death. Clinically significant proteinuria. What is it? Clinically significant proteinuria during pregnancy is defined as the presence of protein in the urine 0 to 3 gram in a daily sample, or in 2 samples taken with the interval of 6 hours. To assess the true level of proteinuria, it's necessary to include the presence of a urinary tract infection. Eclampsia attacked small fibrillary twitching of the facial muscles with further spread of the upper limb, tonic contractions of all skeletal muscles, duration 30 seconds, chronic seizures, spreading of the lower extremities, deep breath, restoration of breathing and consciousness, anemia. Therapeutic tactics, general principles. Stabilization of the condition and prevention of the development of eclampsia. Delivery is the most effective treatment for preeclampsia. Hospitalization in a level 3 hospital. Basic therapy for preeclampsia. Delivery. Anticonvulsant therapy with magnesium sulfate. Antihypertensive therapy. What is the anticonvulsant therapy? It's a magnesium sulfate is a first-line drug for the prevention and the treatment for seizures in the preeclampsia and eclampsia. Antihypertensive therapy. Criteria for starting antihypertensive therapy: blood pressure, systolic 140, diastolic 90. Target blood pressure level during antihypertensive therapy. Main drugs: methyldopa, nifedipine, and metoprolol. Thank you for your attention. Goodbye.